So the most common symptom of vestibular dysfunction is vertigo. The vertigo is a sense of movement when you're not actually moving. So people might perceive that they're moving or their environment is moving when they're experiencing vertigo. So pathologic vertigo occurs with both peripheral and central disorders and arises from a disturbance of spatial orientation in the vestibular cortex. So you can sort of experience something like vertigo that's not pathological when you're sitting in a car in traffic and your car's stopped and the car in the next lane is moving and it feels like you're going backwards. That's sort of a similar thing. However, when you have pathological vertigo, it doesn't stop and there's no obvious cause for it, like the car's moving and the other car's moving and you're not. So vestibular disorders can, besides causing vertigo, they can also cause pathologic nystagmus, which is movement of the eyes, unsteadiness, ataxia, which is uncoordination, incoordination, nausea and vomiting, never good. Peripheral vestibular disorders typically cause recurring periods of vertigo accompanied by moderate to severe nausea. So when you work in a clinic that has a vestibular specialist, you got to have those little blue barf bags because people will have nausea and vomiting during vestibular treatment. Nystagmus almost always accompanies peripheral vertigo. So that is one of the ways you evaluate if somebody's getting better or not. You do different head position testing and evaluate whether they're having nystagmus. You can also, from the type of nystagmus they're having, you can determine where the peripheral disorder is in their vestibular system. Certain drugs can also cause peripheral vestibular damage that can cause vertigo. So BPPV, or benign paroxysmal positional vertigo, is an inner ear disorder that causes acute onset of vertigo and nystagmus. So if we analyze the name of it, benign means it's not malignant. It's not going to hurt you. Paroxysmal, sudden onset of symptoms. Positional, so usually changing in head position is the provoking stimulus. So with rapid change of head position, you get vertigo and nystagmus, and it usually subsides in less than 2 minutes, even if the provoking head position is sustained. So one of the tests that you do for BPPV in the clinic is called the Dix-Hallpike maneuver, and I believe there is a video in Canvas with that. Basically, you have the person sitting up and you move them straight back and turn their head to one side, and you watch their eyes while they're doing it, and you'll see nystagmus. And then there's treatment that you can do right then to get them out of that. So the activities that frequently provoke BPPV are getting in and out of bed because you have to roll and move your head, bending over to look under the bed or look under something, reaching up to retrieve something from a high shelf, or just turning over in bed. So the symptoms are caused by displacement of those little calcium carbonate crystals, those little otoconia, from the macula into a semicircular canal. So instead of where they're supposed to be on top of the jello, they are floating around in the canals and they're giving you weird signals. So the treatment for it is we have movements that we go through to get the otoconia back where they're supposed to be. And the movement that you do is going to depend on the symptoms that you see and where the otoconia are. Vestibular neuritis is an inflammation of the vestibular nerve that's usually caused by a virus. The symptoms include disequilibrium, spontaneous nystagmus, nausea, and severe vertigo for up to 3 days or more. So that's not good. Hearing is unaffected. Caloric testing, which is temperature testing, shows decreased or absent response on the involved side. So this is a case where one side is affected and the other side isn't, and so you get weird signals because one side's working and the reciprocal side's not. During the acute phase, sometimes they'll use medication to suppress nausea. vertigo and vomiting. And because it's caused by a virus, you just have to wait for it to go away. So there's not really treatment that you can do besides um, treating the symptoms medically that's going to make vestibular neuritis go away. So with BPPV, there's a nice physical treatment and exercises you can do, and you get very good results. With vestibular neuritis, you can treat the symptoms medically and wait for the virus to go away. Meniere's disease is a genetic disease. It causes a sensation of fullness in the ear, tinnitus, which is ringing in the ears, acute severe vertigo, nausea, vomiting, and hearing loss. So Meniere's disease is one of the, it also affects the cochlear part of the of cranial nerve 8, and so it can result in hearing loss. It's associated with abnormal fluid pressure in the inner ear, and they don't know if the abnormal fluid pressure is the cause of Meniere's disease or the effect of Meniere's disease, but it tends to be genetic. So drugs that suppress vertigo are used during acute attacks. In extreme cases where the vertigo doesn't go away, sometimes they actually surgically sever the vestibular nerve to relieve symptoms. As you can imagine, this is going to cause issues with your balance. So that's an extreme case. But so the treatment for Meniere's disease, you can't make it go away. You can treat the symptoms when they're acute, but you can't make it go away. Okay, where do we go? Perilymph fistula. The perilymph is the fluid in the space between the bone and the labyrinth. A perilymph fistula occurs when a fistula is always an opening where there's not supposed to be an opening. So you get an opening between the middle and inner ear, allowing the fluid to leak from the inner ear to the middle ear. And it causes an abrupt onset of hearing loss with tinnitus and vertigo. Most of the time it's caused by trauma, like a car accident or something, and it requires surgery to correct. So that's not something that we can treat in PT. But a vestibular specialist can screen it and know to refer them to the surgeon. Traumatic injuries can cause like a perilymph fistula. It can cause concussion of the inner ear, fractures of the bone surrounding the vestibular apparatus and the vestibular nerve, and pressure changes in the inner ear. So any of those injuries can compromise vestibular function. Um, the vestibular input also has a role in motor control. It helps with gaze stabilization through the vestibular ocular reflex and postural adjustments through its connections to the cerebellum. So the vestibular system is super important. And I always tell people in the clinic, you have 3 major sensory inputs for balance. Your vision, your vestibular system, and proprioception. The messages going back and forth from your extremities to your brain, basically. And so I tell them eyes, ears, and feet. So you can train, if you have one system that's weak, you can train the other systems to compensate. But the vestibular system is really important in those 2 areas of motor control. Central vestibular disorders versus peripheral, all the ones we've talked about so far have been peripheral. Central vestibular disorders result from damage to vestibular nuclei or connections within the brain. So, interestingly enough, central disorders typically produce milder symptoms than peripheral disorders. So, if you have really terrible vestibular systems, it's probably a good thing because it means it's peripheral, better than it being central. Again, there's not really much you can do to treat it. Most of the time, central vestibular disorders are results of ischemia or tumors in the brainstem or cerebellar region, cerebellar degeneration, MS, or Arnold-Chiari malformation, where the bottom of the brainstem is coming out through the foramen magnum. I have worked with people who have basilar vertebral artery strokes that cause cerebellar dysfunction and cause dizziness. So that's sort of a central vestibular disorder. So we can work on compensating, but we're not going to cure the problem. In rehabilitation, it doesn't directly affect central dysfunction, and it's kind of ineffective for Meniere's disease, but it's very effective for BPPV, unilateral vestibular loss or dysfunction, and bilateral vestibular loss. Central vestibular disorders benefit from movement retraining in a compensatory way. So you're not going to make it go away, but you can retrain to compensate for the disorder. In rehabilitation, we usually have exercises that are designed to promote movement retraining, vestibular habituation, or substitution to improve function. In movement retraining, we're going to practice and modify movements. It's kind of what we do in PT, right? Habituation, we're going to expose the patient to positions or movements that produce the symptoms, followed by relaxation until the symptoms abate. So BPPV often responds to habituation exercises. Substitution, using alternative sensory inputs or motor responses, or using predictive or anticipatory strategies. So we're using different strategies to substitute for the movements that aren't working for us.